And now it's Deborah Kobylt Live.
Hi, everybody, and thank you so much for joining us today on Deborah Kobylt Live. And I'd like to mention before I introduce my guest, thank you to the National Press Club. I was just nominated for 2 National Press Club awards, and I'm absolutely thrilled about that. And we'll find out in December. We'll see what happens. But I was just thrilled about that. Now, to introduce my guest, Dr. Sherry Ross. I've known Dr. Sherry for quite some time. Dr. Sherry is a hormone and menopause specialist, famed obstetrician and gynecologist from Santa Monica, starting a new podcast next year called Paradox. We'll talk about that. She's been involved in the wellness space, but really involved to help us sort of navigate what's happening to our bodies as we change, right? As our bodies change. And we're going to be talking about menopause, hormones, and also I believe you recently launched menopause oh my God, I can never say telehealth platform, right? So we don't have to go into the office. You can talk to us about what's happening, which I think is very helpful for people. So, gosh, that's a mouthful. But thank you very much for joining us, Doctor.
Oh, Deborah, thank you for having me. I'm so glad to be back with you to talk about all things in women's health that people aren't talking about.
Yeah, they're not, or they're confused, right? I know I'm confused. I've been confused. Let's talk first about menopause. I didn't get hot flashes. I didn't get all that stuff. But I probably got rage and didn't realize it was rage. I was just pissed off all the time. But if you said to me I was in menopause, I'd be like, no, I'm not. But I think I was, right? Or now that I look back on it, I'm thinking, oh, yeah, I was. So people are confused about what menopause is. When does it begin? And
Hmm.
hormones and hormone therapy. We got to break that down. So please take it away.
Yeah. You and the other half of the population are confused. And, why is that the case? Well, it goes back to, studies that were done that were misleading. It goes back to doctors who aren't really being trained in medical school enough about this normal, we call menopause transition now. It really can affect anyone from their late 30s and beyond. And it's a confusing time because, things are happening with the ovaries. They're not producing estrogen regularly. And then all of a sudden they stop producing, estrogen, and then testosterone's involved. And there are over 100 symptoms. So you mentioned mood. What happened with you? What was your memory?
My memory, I think I was just in a rage. And I feel kind of badly about that. My kids would come home from school and the usual me was, oh, how is everything? And instead it's like, put your stuff away. It's like, oh my gosh. I didn't
Yeah.
realize what was happening. I just thought I was in a pissed off mood. But I feel badly about that because I figured menopause is something I have to be sweating it out at night or all types of other symptoms, which I never, ever, ever had. But now looking back on it, I could see what I did have. And I didn't go on any hormone therapy. I don't know if it's too late. So we'll talk about that too for people who didn't start
Yeah.
because my mom had breast cancer. And the studies at that time were saying, oh, you can't go on it if there's breast cancer in the family. And I just never did it. Now I have friends on it now and they say, oh, the testosterone. I'm like, testosterone? What do you mean? See, all of these things I don't understand
Confusing.
are confusing. That's why, we're
Yeah.
here to have you break it
Very.
down. Yeah.
Yeah. Well, that's the problem. Mood, for example. Um, it may not be the first symptom you notice, but it's definitely up there. Vasomotor symptoms, hot flashes, night sweats are the more common, followed closely by mood changes, depression, anxiety. And if you have any predisposition to depression, for example, you're going to be more at risk for
Mm.
noticing more problems with your depression or anxiety. So it just depends. And because there's over 100 symptoms, really, and we're finding them out, as they're coming along. I mean, we know that in your late 30s, estrogen starts to decline. It may be your 40s, you're having irregular periods, hot flashes, night sweats, depression, anxiety, fatigue, and then weight gain, bloating, shoulder pain, frozen shoulder, muscle. I mean, the list is very, very long. So you go to your doctor for help, and especially in perimenopause, which is really 10 years before the average age of menopause, which is 51. And they do blood work and everything's normal. So your doctor says,
Right.
hey, you're good. You're good.
Exactly. It's
Come back when you
exact.
don't, yeah,
Oh my
come back when
gosh.
you don't have a period for a year.
So then,
And this is the confusion.
do you take special tests?
Yeah, this,
Like probably not just the baseline, but you
yeah.
probably go deeper. Talk about that.
So there are tests you do. You look at your ovarian hormones, which is FSH and estradiol, and that FSH, follicle stimulating hormone, that's the sensitive test to look for menopause. So it has to be over a certain number. Often it's around 25. And then no period for a year, that equals your diagnosis of menopause. But we know the story and the symptoms tell something very different because women are suffering. I mean, women are not sure what to do, like yourself, are hormones safe? So first is sort of identifying what symptoms are bothering you. What are they? Are they noticeable or are they disruptive? Where do you fall into that? And then hopefully your healthcare provider will then guide you through, treatment options.
Talk to me about some of the hormones that dip as we're going through menopause. Which ones are they?
So estrogen, of course, is our superpower hormone, progesterone. And then, we're talking a lot about the androgens, right? The male, traditionally male hormones. Well, that's testosterone is one. And that's significant because it has a huge hand in not just, sort of sex drive, which we know it to affect, but also energy, brain health, right? Cognition. There's heart benefits and bone benefits from testosterone. So testosterone, we're really shining the light on, and how we can now safely incorporate it into our, treatment cocktail with hormone replacement therapy.
Hmm. I was talking to a friend about that because she told me she is on, a cocktail of hormones, including testosterone. And of course, my first question was, "Oh my gosh, are you growing hair on your chin? Like, what is that like? What is it?
Right, right.
How does our body respond to testosterone?"
Our body loves testosterone. I mean, we
Oh,
we we know it well, right? I mean, it's produced in the ovaries, but it's also produced in different glands, what's called the adrenal glands, and it's produced, peripherally and outside other tissues. So it's really present, in our hormonal stability. So what we used to, the problem with testosterone is we're trying to figure out how do women use it safely? What is the dose? What is the
hmm,
protocol? And the data is, it's coming. It's an off-label treatment for sex drive, for low libido, which, affects so many of us. And but we know it has a hand in other areas of our wellness, and fatigue is one, and our ability, concentrating, our mental stamina, and what's happening there. And it really does matter, but because it's not FDA approved yet, they're working on
ah,
it. um, this also creates additional confusion from healthcare providers.
hmm,
What are the safe dose? We sort of know that compared to men, it's about a tenth of the dose that men take.
hmm,
So that we know, but then where's the prescription? And so a lot of times we're using compounding, ways to make testosterone usable. And
hmm.
and I think the confusion, and you'll hear your friends getting it in different forms and pellets and creams and suckers. And what is the right dose? How often do you monitor the testosterone? I mean, this is the other confusion. So it's we're trying to figure out the roadmap that's safe for patients and maybe more streamlined so other doctors know how to prescribe it. And then, of course, insurance doesn't cover it, for the most part. That's the other kind of failure barrier to use.
Of course not, right? I mean, it's our female health. Do they cover other hormone therapy treatments?
So yeah, so the traditional hormone therapy of estrogen and progesterone, they do cover. Um, again, it depends, what format you're taking. Ideally, you want to use a transdermal patch. That's the safest way to
Mm.
take estrogen as opposed to oral versions because the transdermal, it bypasses the liver, so there's less blood clot risk. There's less risk of affecting your testosterone, your sex drive also, and it doesn't really affect your triglycerides. So ideally, in a perfect world, women are going to use the transdermal form. So that's either a patch or a gel or a cream. Then the insurance company is going to decide what they're going to cover. And unfortunately, Deborah, they don't always cover the transdermal forms. And that
Right.
unfortunately is, so then we're left with the oral version. And there's just a slightly more risk of blood clots and effect on sexual health.
Hmm. Now, when should a person start taking hormone therapy? Is it when, like, before they start losing their period? Like, when do you do that?
So listen, it's a great question. So it all depends on your symptoms, right?
Hmm.
All these symptoms that you can have. So in your 40s, most women up to 80% are going to get irregular periods. And that can either be good, they can space out, which wouldn't necessarily be a bother. But if they come every 2 weeks and they're lasting, 7 days, 8 days longer than your normal period, and you've got blood clots, then it's disruptive. So we could put women on the birth control pill. That's sort of the
Hmm.
first line for that age group, and in part because they still can get pregnant.
Right.
And we don't necessarily think about that, right? You may not be having a monthly period, but you can sneak in ovulations and get pregnant. So there's a high pregnancy rate or unplanned pregnancy rate in perimenopause. But you can also use hormone therapy. And again, as long as you're low risk, you don't have any, breast cancer, you haven't had any blood clots, no liver disease or any estrogen sensitive blood, other tumors, you can safely take hormone therapy. And again, it's this, how disruptive are the symptoms? How much of your quality of life is being affected? Because all those people all those
Hmm.
people can safely take hormone therapy, and really all the symptoms will essentially go away for the most part. I mean, there'll be, the weight gain struggle is real, um, but it definitely can help in every symptom that menopause hits us with.
Hmm. So let's talk about me for a minute.
Yeah.
um, I always love to, put myself out
I
there
know.
as a bit of the guinea pig. I already told you that, my moods were just up and down. It was really crazy. And
Yeah.
also, weight gain. Those were my two symptoms. I don't think I had much of anything else, not that I could identify easily the way I can identify this. What would be the best type of therapy? Would it be the cocktail of all three? Like, how do you even assess this?
Yeah, I mean, it's a good question when it comes to mental health because,
Mm.
I would want to know, have you been on an antidepressant or a mood stabilizer in the past? And if so, often you're going to be talking to your therapist to say, hey, do I need to bump up my dose of, whatever antidepressant you might be on? And then you add in hormone therapy with, sort of whatever you've been taking, and people do much, much better with the combination,
Hmm.
especially for getting back to your, normal mood that makes you functional and not, screaming at your kids or your partner. So it does work in combination very, very well. And doses sometimes have to be bumped up a little bit when it comes to your antidepressant or anti-anxiety medication.
You mentioned partner.
Yeah.
How do you involve the family? How do you involve your partner in all
Oh,
this?
you
Who
have to.
No, but no, I know. But if you can't figure out what's going on and they can't figure out what's going on, which is what was happening in my
Yeah.
family, nobody knows what to do. Like, how can the partner
Yeah.
be better educated to say, I think this might be happening, as opposed to, what are you, crazy? That's
Yeah.
not going to help anybody. Like, how do we identify, and how can we help partners identify? And even kids, you don't want them to go to school feeling awful, like, gosh, what did I do
Yeah.
wrong? Maybe this is something that could even be, I don't know, brought up in curriculum. Like, if this is happening,
Absolutely.
do you know what I mean? So I want your thoughts on all that.
Yeah, I mean, absolutely. I mean, menopause is a family issue.
Yeah.
Perimenopause, menopause, I mean, everyone has to really understand. So we already are having trouble educating patients and women, right? So we're even having a bigger struggle, really educating first and foremost your partner because it is affecting them no matter what. So
Yeah.
what I like to do is I will invite the partner to join, my visits.
Hmm.
I will do it. Sometimes it's a telehealth visit. They'll get on the phone. I'll say, I'll remind my patient, hey, let's bring in your partner. Let's talk about what's happening with your mood, why you have no interest in the bedroom. You don't even like your partner right now. You're angry. You're feeling badly because you're gaining weight. You don't understand. You're doing all the right things. So you don't want to get naked either. So there's many reasons why. And as soon as I invite the partner into this conversation in some shape or fashion, all of a sudden there's sort of the clouds part and everyone's
Hmm.
feeling very comfortable and joyful. And it's almost like a date. We kind of create like a little date visit
Oh, that's cute.
with
I like that.
me. Yeah, and everyone's very appreciative, but we have to, as educators, as doctors, we have to bring them into the conversation um, so that you can have your family meeting. You can go home to your kids and say, "Oh my God, I am so sorry. This anger, this is not all just me. There's some real medical reasons, and I'm working on it, and I'm sorry, and I'm going to work on it, and it will be better." So to some degree, you have to choose the conversation in words that people understand.
I love the telehealth aspect that you're doing. Let's talk
Yeah.
about that
Oh
because
my.
I personally don't love showing up at the doctor's. No offense, I think you're lovely, but just going there,
Yes, yes, yes.
parking, dealing with traffic, finding money to put in the meter. By the time I'm there, talk about a rage. But I'm serious. It's like then you're sitting in the lobby waiting for whoever your doctor is. It's like, oh my gosh, then you forget what you're even there for. So the fact that you
Exactly.
right, at least that's me, the fact that this whole telehealth thing, I think is fabulous. Talk about it.
Yeah, I am so excited to be a part of this venture. So, menopause hormone therapy, we just launched it on the Quick MD
Mm,
app that's been around. It's a telehealth company that's been around for a few years now, dealing with fentanyl and Suboxone treatments. Uh, what telehealth does, and what I love about it, is it creates access to care that millions of people do not have access to.
mm.
And what is nice, and I really believe it's the future of medical care for millions that don't have, the ability to hop on a, you know, 20-minute, 30-minute telehealth meeting that day. I mean, our quick MD um, menopause health platform, you can get on the same day, for, actually we're giving away, free treatment right now, but even everything under $100 to understand what am I going through? What are my symptoms? We're focusing on the menopause transition, which is perimenopause and menopause. And it's just accessible health with treatments, and it's fascinating. And I'm just so happy to be a part of something that's very forward thinking. And it's a wonderful platform.
Yeah. How long are, the appointments generally? And I guess anybody could call in with that. And do they take
Anyone
insurance?
Um, we don't take insurance yet, but it's very cost friendly. Our visits are right now they're free, but they're going to be $79. So
Mm,
the mission of QuickMD, there's a lot of compassion with this is, really they want to be a service for all,
yeah.
understanding we have a broken healthcare system, and they want to be able to say, hey, you can get on today and see a doctor in the afternoon or in the evening or before work during your lunch break and get explanations of what's happening to you and then get treatment. So it's fantastic, and I think telehealth is our future
Yes.
until we can figure out the crazy problems with our current healthcare system, which I'm very disappointed in. If the average time that a patient spends with their doctor is 7 to 11 minutes, Deborah, that's unacceptable. So at least, our visits are, anywhere from 15 to 20 minutes or more, depending how, what your concerns are. but they're also could be monthly or every 2 months or 3 months. So I think it's at the right time to be looking at alternative ways for patients to get care.
Now, if they go on this app, they can request you and specifically, like how does that work?
Well, depending, I mean, I am doing visits, but if, today at 3 you're available, I may be your doctor and you can kind of see who's available
I see.
depending on what state you're in, because we're going to be doing this in all the states in the United States.
Hmm. I love this. I think this is fantastic.
Yeah,
Let's
me too.
yeah, let's talk a little bit more about. I mean, we talked about it a little bit, but patches, creams, pills. Do the
Yes.
patches come in like a, a multi hormone in that patch, or do you have to have different ones? How often do you change it? Example, once again, for me, oh my gosh,
Okay.
I always forget to take pills, right? Somebody will say,
Yes,
did you take
yes.
your pill? I'm like, oh my gosh, I forgot again. In which case, it just doesn't work for me. But a patch, that could be great.
Yeah.
Is that a weekly thing? Talk to me about how that works.
Yeah. So again, there's different companies that make it. The most common way of using it is a patch to be used every 3 days. You put it on little below your belly button, and it gives us kind of a slow release of estradiol, the one that I like to use. And if you have a uterus, you have to take progesterone with that patch because if you just took estrogen alone, you're going to be at risk for, precancer or cancer cells of the uterus. So the two hormones work the best, and those are the two that we've been using, since puberty. So it's very familiar to our body.
Right.
Progesterone, you take at night. That's daily, at least in this kind of regimen. There are patches you can do once a week. But the most common way of taking it is every 3 days, and you change it every 3 days, and you take your progesterone at night.
Hmm.
And there's different iterations. I mean, if some people don't want to take a patch because they don't like wearing the Band-Aid, if they swim a lot or in water or they take baths, they may not like that feeling of having a Band-Aid on their skin. And then they can take the oral version, and that format you would take daily. Again, if you have a uterus, you take it every day with the progesterone. And there's also a one pill with both estrogen and progesterone in it as well.
Hmm. So there's options, right? There's
There are
options.
options, and like I said, there's the cream form, a gel form, and these are the ones that are recommended and sort of approved for hormone therapy in menopause.
What if you're on the other side of menopause, or you think you are
Yeah,
anyway?
that's
Um, then what do you
that's a
do?
great
Should
question.
you still go on hormone replacement therapy, or are you done? Like, what do people do?
Yeah, this is a question I get a lot. So, we kind of call it menopause, and then the next stage is postmenopause. But here's the thing. You're in menopause for life, right?
Hmm.
You are really, your body is affected. Every cell, head to toe, for the most part, has estrogen receptors. And
Right.
so, it's again the confusion about, well, when do I stop hormones? It used to be 10 years, 10 years, 10 years, right? That was
Mm.
what we were taught. And again, we know this. If you take estrogen within the first 10 years of menopause, that is you're going to be your greatest benefit for heart disease protection, for dementia. So you get cognitive benefits and, of course, bone benefits, right? So the first 10 years is really the sweet spot and where all women really want to focus. Now, beyond that, right, there's been confusion. Do we stop? Do we not? They just came out with this great study. It was a Medicare study of like, millions of women that started taking estrogen, that were taking it beyond the age of 60. And they found that this group of women really had a decrease in all cause mortality.
Oh,
So
wow.
all the things that can cause harm to us were improved. And this is, heart health again, looking at different cancers, breast cancer, lung cancer, colon cancer. These are the top three cancers that women get. And there was protection against these cancers even beyond the age of 60. So we're not
Wow.
saying stop hormones. In fact, we're encouraging. hormone use beyond the age of 60 for all these benefits. And I think, dementia, heart disease, these are matter. This matters to women. One of four die of heart disease related issues. So staying on estrogen to the low risk group of women beyond the age of 60 is now encouraged. So
Wow.
we don't really stop it. And let's talk about the vagina because our vagina is really held hostage in menopause. I mean, the changes that happen from lack of estrogen in the vagina and bladder, they are progressive and they're sneaky. So you may notice dryness, right? You're a couple years beyond menopause, you're like, God, I have dryness with intimacy. When I have sex with, if you're using a penis, I have pain. And this is the very, the condition we call is genital urinary syndrome of menopause. And it affects up to 70% of women. I mean, everyone's complaining about it in my office. And then, it's later onset where people really come in and they're noticing tears with penetration, with they're having intercourse, dry, not getting wet. They're just really having, it's a horrible experience. So it's not just here's a good lube to use, but what can we do preventatively? If I told you this is a predictable problem, that it may not happen within the first couple of years of menopause, but after 5 years, you will be noticing all these symptoms. And then urgency, frequency, UTIs, in addition to vaginal dryness, you should go start taking vaginal estrogen as well.
Oh,
Again, it's very safe, and I recommend it as soon as I put a patient or identify them as being in menopause and they're safe to use hormone therapy. I automatically put them on some vaginal estrogen form as well because we know it's going to help anything sexual related and most importantly, bladder issues and urinary tract infections. So, very, very important. And vaginal estrogen is super low risk. I mean, no problems related to any cancers or anything like that. In fact, I have most of my breast cancer patients also using vaginal estrogen. So if it's predictable, it's preventable. And when it comes to the genital urinary syndrome of menopause, vaginal dryness issues, bladder problems, estrogen is your best friend.
man, I've had bladder problems my whole life. I was 5 years old and I had bladder problems. I swear it is an
Wow.
issue for me. The other one you mentioned, never an issue for me at all. I didn't get any of those symptoms. But the bladder, oh my gosh, I could
Yeah.
barely make it anywhere. But
Well,
when you,
we got to get you on some vaginal estrogen.
let me ask, is it a suppository, the vaginal estrogen? Tell me, how is it? How did we use
Okay.
that?
So again, there's different ways of using vaginal estrogen. There's a cream form, there's a pill form that you insert into the vagina, there's suppositories. Those are the most common. There's also a ring form that can stay in the vagina for 12 weeks and do a slow, slow distribution of vaginal estrogen. It's going to be, comes down to, as always, what your insurance will cover, what you're comfortable doing. My favorite one, and the one that I find that patients have good compliance, I always say they do their homework better, is with Vagifem. It's a one-time applicator with a little baby aspirin size tablet on the end, and you insert it into the vagina. Um, Super easy to use, no mess, no leakage, and the results are phenomenal. They're just patients are so happy and they're very
That's
grateful
great.
and their partners are too because you're not wanting to avoid intimacy, you're
Yeah.
not worrying about pain with sex, dryness, lack of
Right.
lubrication. So
Oh
it's
yeah.
really, really nice, really nice.
Yeah, I mean, happy vagina, happy partner. So, I mean, that's
100%.
that's great. Um,
100%.
let me see what else. I had something else to ask you. You have two books that you published, right?
Yes, yes.
Tell us about that.
Yeah, so she-ology was my first book,
Yeah,
The Intimate Guide to Women's Health. Uh, in fact, that's when I came on your podcast. We talked
yeah.
about it. This was back in 2017. Um, you know, what I found, when a woman's legs go up in stirrups, I really got to
Oh,
hear really what the issues were. All of a sudden women were talking about their labia, their lips, their partners were saying, "Hey, your labia, your lips are elephant size." So they'd come in,
oh my
they'd be
God.
very upset. They'd want to know, what could I do about it? Am I normal? Because of porn, the influence of porn. And everyone wants the perfect vagina. So I felt very compelled to address some of these common, taboos and insecurities that I was seeing here in my office, and really kind of wanting to re-educate women on very common problems that weren't being discussed in our sex ed classes, weren't being discussed. I grew up with our bodies ourselves, and I felt very limited on what was normal. I mean, again, who's talking about these, taboo topics? And so that's how I started my first book. It was, one of the is kind of looked at as sort of a new conversation.
Yeah.
I was very excited. It was honored in a couple of magazines, and just for nuances. And then I had to do the second book, my she-ology, the she-quel. Let's continue the conversation, because there was so much to discuss. And I was very excited. I was very passionate about putting out information that wasn't really being had.
Hmm.
So I'm very proud of it, and it was fun to write, and I think it's been very helpful.
I can't believe that somebody would actually say that to their partner, that you look like you have, elephant, whatever. I mean, I would kick them out. I mean, that's just unbelievable. That's rude. That's
Right.
mean. But gosh, what a terrible thing to do to someone. And then imagine how they feel showing up again to get intimate. They're probably thinking, I don't want to do that. What do you tell them? You tell them to go get surgery? I mean, what do you tell a person?
Yeah, so this conversation of how normal are my labia? I get it a lot, right? I get it a lot because, like snowflakes, no two are alike. Anything in our body
Yeah,
in pairs, our breasts, our eyes, our ears, nothing is the same. So you already notice something like, oh, they're not the same. Well, that's normal. Um, Most labia are normal in their proportion, as far as they vary in length and size and thickness. Now, there are an outlier group of labia where they're excessively long, or they stretch, a few inches in length. And I had this one gal who was 16, and she was on the swim team, and she came in to see me, and she said, I have to tuck in my labia when I swim because it kind of protrudes in my bathing suit. So there are people that do need some reduction.
yeah,
Um, when the labia gets in the way of daily life, like exercising or with intimacy, if the labia are being dragged into the vagina during penetration, sex, for example, or you're having pain or discomfort with certain exercises, then we do trim them.
yeah,
And same can happen around the clitoral hood. There can be redundant tissue. So there are times when it's legitimate, but for the most part, I'm here to tell you your labia are normal. Um, and again, we have to realize that the influence of porn has been very, very toxic under the sheets,
yeah,
from the screaming and the yelling, and how women have their orgasms. Some people come in and say, well, I don't scream like that. I feels good and I reach orgasm, but I don't want to yell out like banshees. And it's like, again, we're all, we all have to look at things of where is the source that they're getting it.
yeah,
And so this young woman that came in, and her partner said, you have Dumbo ears, of your labia. Of course, it was a conversation of, well, let's really talk about this person. And, what can we do to really dispel the myth? And, you need to have a talk with your partner to, not be talking to you that way. Actually, she broke up with him, as it turned out, anyway. But
thank goodness. I
um,
mean, what a jerk. Honest to God. I think that's so rude. Good. I'm glad she left him. I really
Yeah,
am.
yeah. There's a
Um,
happy ending there.
are
So
you still
yeah.
okay?
Go ahead.
Are you
Am I
still
still baby?
delivering babies? Yeah. Are you doing that currently, or did you
So
transition to doing this space?
I'm transitioning a little out of obstetrics
Yeah.
after 35 years of doing OB. I love it. It's still so joyful, and I still do a couple monthly. But really, my passion is in educating women and men and all they, whoever you are, come one, come all. There's just so much to talk about. There's so many misunderstandings out there, so many taboos, so much misdirection in healthcare, and
Yeah.
how that impacts us, as you know. I mean, it affects our self-esteem, it affects our self-love, and until we can really find that first and foremost and understand what's happening in our bodies, you can't really have a good, healthy relationship, right? And you have to have it first and foremost with yourself.
Yeah, you really do. Yeah, you mentioned that when women come into the office and they're up in stirrups, that's when they start talking. I know for me, I'm such a nervous wreck that I'll start talking about anything, traffic,
Yeah.
this, that. It's like you just want to keep the conversation going until it's over. I'm not one who's super comfortable going in to get that exam. I never have been. I'm imagining most women are like that, right?
Yeah, I'm not their top three doctor visits, but you
Got to
know,
go.
uh, well, at least the top three to get a pap smear. But you know, I often, and for a lot of the younger new patients that I see, I may not even examine them. I may
Oh,
just sit in my office and talk to them
hmm.
to establish comfort and to establish a relationship, because you have to have a healthy, connected relationship with any doctor, honestly.
Yeah,
But especially your gynecologist, obstetrician, because it is such an intimate time, and you want to have a open conversation, and you hope that they can ask you questions, and I think it's incumbent on healthcare practitioners to initiate some of the more delicate conversations, especially around our bodies and our sexuality and our bedroom activities, and just make sure everything's working, right? I
yeah.
mean, I'll pull out the mirror and I'll show women their anatomy. And Deborah, women all our ages haven't really taken a look, right? Have you taken a
Yes.
look?
Yeah, I
Yeah.
have.
And
And I'm like,
and
not bad. So it's, I'm
not, not bad.
like, all right, it's
But
not so bad. You're okay. So, yeah, I have, because, we're all curious. But
right,
I
right.
have a question. You mentioned pap smears. How often should we get them over a certain age? Let's say you're post menopause or you're sort of past that particular point. Should
Yeah.
you still get them every year, or is it every other year? What do you recommend?
That's yeah. So it does. We've been spacing them out over time. You don't have to get your first one until 21, which is good, and then it can be every 3 years. Thereafter, it can space out to every 5 years if you've had completely normal PAPs. So if you're over 50, you're in menopause, and you've had normal PAPs, they can go to every 5 years, and
Oh,
then depending after 65, they can even stop. But the real catch is, what is your HPV status? Because
right.
HPV, up to 80% of women carry that virus, up to 90% of men carry that virus. And it loves to hang out in the cervix. And so if it
Mm,
goes to the cervix, we can
yeah.
find it. We can find it doing pap smears. And we know there's an association with cancer of the cervix and cancer of the anus, oral cancers as well. Getting the HPV vaccine, and that's as young as 9 and as old as 45 for women now. They've extended the vaccine guidelines. It's really reduced the incidence of cervical cancers and other cancers, but primarily cervical cancers. So getting a PAP is going to be individualized based on your HPV status as well.
Hmm. Fantastic. How can people get in touch with you? And is there anything else that you want to mention that we didn't even talk about? There's so much, I know there is, but I want to make
There's
sure that
so much.
there really is, that we get across what women that I know are in a certain stage in their lives. I wanted to dispel so many myths out there, which I think you did a pretty good job of. But is there anything else you want to bring up? or you want patients
You
to
know,
know?
I think it's so important to empower yourself with your health care. Get
Mm,
information, go to reliable sources. It's always about the source.
mm,
I love medical platforms like, places like WebMD and Mayo Clinic. In part two, Deborah, that's why we started this podcast,
mm,
Paradox Podcast, because I'm with a Dr. Tammy Nelson, who's a sex therapist and actually a couples therapist, just an incredible therapist on many fronts. And, we're really talking about these kind of conversations. We're two experts, zero filters, whole truth. That's our tagline because we want to engage people, not just medical experts. We have a whole variety of people coming on talking about their health and experts bringing in their conversation so we can be a reference, so we can be a place where people can come. And we want to be part of this mission. We want to lock arms with different people, different educators, different places where people can come to get really reliable healthcare information.
and that's called Paradox, right? When can people find it, and where can people find it?
Yeah. Well, it's going to be launching in January. We've already shot about 15 episodes. We've had
Mm.
some incredible healthcare experts from Gabor Mate, Frank Anderson, to celebrities, Jane Seymour, Burke, different healthcare experts too. We're just trying to bring in, people who can talk about these topics. I had Rachel Rubin for menopause and issues and the vagina hero that she is, and Kelly Casperson talking about testosterone that you'll really enjoy. Not sure where it's going to be living yet, but our goal is just to really create the conversation. And as I'm doing with the menopause hormone therapy on QuickMD, there's going to be a lot of educational content there. So empower yourselves um, and find right places to really get really reliable information.
Mm. Thank you so much. Are you
I'm
taking
also,
new? Go.
I am taking new pictures. I'm also on Instagram. So Dr. Sherry R on Instagram. You can find me there. I also do she-ology on Instagram and control.menopause for my quick MD platform for menopause health.
And that's Sherry, people. That's how you spell it. Because sometimes even I'm
Yes,
confused. I'm like, wait, is it 1 R, 2 R's? How do I find her? And you're very good at answering. I find people are terrific at answering their messages on Instagram, right? Because
I do.
it's not too
I do.
personal. It's not like you gave them your cell phone, but
I
it's a
do.
really great way to communicate with people. So if they have questions, yes, I'm gonna ask people to please go to your Instagram at she-ology and also Dr. Sherry, Sherry
Yeah.
R for Ross. And
Yes.
and any questions, just go ahead and write
Yeah,
to you.
reach out. People email me all the time, and I get emails from all over the world, and I understand the need for conversation. So I want to be helpful. I really do.
Yeah, and you have such a great demeanor.
Thank
If you come
you.
into the room anxious, you're going to leave much less anxious. That is something that you're very good at doing to people naturally. That's just how
Thank
you
you.
are naturally. So I appreciate that, Dr. Sherry.
Thank
So
you.
please, everybody, Dr. Sherry Ross, look her up on Instagram, look up her practice. She said you said you're taking new patients, right?
I am. Yes, I am. Yes. Thank you, Deborah.
Also, yeah, also telehealth as well. If you have questions, this is
Yeah,
really
come.
important. Yeah, this is
Yes.
important because I'm someone who doesn't even want to ask a lot of questions. I'll just be like, oh, it'll pass. Don't do that. You deserve better, right? We all deserve a little better and get some answers to the questions that we're having. It's nothing to be ashamed about or embarrassed. We're all going through it. So, God,
Exactly.
gosh
Exactly.
knows. So, everybody, thank you very much for joining us today on Deborah Kobylt Live
Thank you.
with Dr. Sherry Ross. And you could find our show on YouTube. We do put it up on Facebook. And then as an audio podcast on iHeart, go to Spotify, wherever you get your podcast, just look up Deborah Kobylt Live and Dr. Sherry Ross, and you'll find our interviews. So, Doctor, thank you again for joining us.
Thank you. Thanks for having me. Always
And
appreciate it.
yeah, absolutely. And we'll see you all next time. Bye bye.